Hi, everyone. Thanks for joining and tuning into the Buzz Podcast presented by Quality Rehab Management. I'm your host, Casey Lee, and piggybacking off of the last episode where I discussed some options for therapy teams that share staff or maybe teams that are in rural locations. I offered the option of a remote note where an evaluating therapist would complete documentation remotely after a thorough documentation review and collaboration consultation with their assistants that are performing the interventions on site. The evaluating therapist would complete documentation remotely instead of performing the visit and the documentation on site, which historically has been the best practice. But in the midst of pandemic, we're trying to reduce the spread of COVID-19, particularly in our long-term care facilities. And the less people moving in and out, we just know that that's the new best practice. Keeping the virus out of our facilities is the number one goal. And of course, if it gets in, reducing the spread within the facility. So I offer that option, and I'm going to be sharing, I've been doing a whole lot of documentation audits, therapy documentation audits, to try to offer some support and guidance on how to do this as correctly as possible, right? This is different. We haven't done this before. We're opening a new door. We have not been through this door before. So I'm reviewing documentation and I'm looking at notes using my PT lens. I'm a physical therapist and when I'm reviewing documentation, I'm thinking about, okay, if I were the supervising PT and this was my patient and I cannot get in front of this patient because it's unsafe, but I need their program to continue uninterrupted, what information can I gather from my assistant's documentation, and what questions do I want to ask my assistant when we have that rich, important conversation prior to me completing the therapist progress report, which will then progress the plan. So I'm doing a ton of behind the scenes auditing, and I will have information to share on how to do this. So stay tuned, tune in again, subscribe to the podcast, and share this with your evaluators. Today, it's March 26th, and we're on the cusp of doing e-visits with potentially opening the door to telehealth. That is we are not authorized providers of telehealth services under Medicare, physical therapy, occupational therapy, and speech therapy. But that does not mean that this time next week that we could be. So stay tuned, because these are also things that we're looking at, we're thinking about, we're coming up with best practices now to get ourselves ready to educate and train. So all of that is coming, some documentation, audit, trending I'm going to share after I've had a chance to look at all of our buildings across all of my clients. And then share some information on how PTs and OTs can best supervise and progress treatment plans remotely. But really, what the purpose of the remote note is to prevent COVID-19 from getting into your building, prevent it from spreading around, because the less traffic in and out, the less people moving around, the better. But there are going to be times where you have therapists that travel between locations. There are some tasks and some situations that there's just no way around it. And I mentioned in the last episode that, an initial evaluation, really until we have access to provide telehealth under Medicare, we cannot do, an evaluation is an on-site, in-person part of the treatment plan. The initial evaluation cannot be done remotely through audiovisual telehealth services, can't be done. So that is an on-site. So if you have a patient with a new condition who's not on caseload, well, the answer isn't, well, I can't send a therapist there, so they just don't get services. That's not the answer, because we're essential and our services are essential and we're going to provide that service. We need to find the safest, most practical way to do it with containing the risk of spreading COVID-19. So here are some education that may be options for you to share with your therapy teams if you have therapists who float. And therapists know this and rehab teams know this. If you're, you may or may not know this depending on what your role is in your facility, but the historical model of therapy staffing is typically an assistant doing the base treatments at a facility. They stay in one facility and treat the majority of the patients for continuity. And the evaluating therapist, depending on the size of the caseload, may float between multiple sites to provide the oversight of the programs, to complete the evaluations, to progress the plans, to provide that clinician input and integration into the plan. But the clinicians, the supervising therapists, they may be responsible for 2, 3, maybe even 4 different facilities. Okay, that's a normal model. We've had that model forever. And when there's not a highly contagious COVID-19 virus out there, it works just fine. So we will get back to that model. But for right now, we really want to contain and keep people from traveling. But when you have to have someone float and travel, someone who goes to other facilities, you want to keep that in mind, that the risk is higher. And so here are some strategies that may work for you to share with your therapy teams and the therapists who float to contain and reduce that risk of spreading the virus, spreading infection. So first, sanitize before you get into the building, as soon as you get in, and the same with exiting. So if I'm a therapist who's traveling and I'm floating to a building, of course I'm keeping my hand sanitizer in my vehicle, and I'm wiping down the inside of my car. This is me. I've got my wipes, but guys, the wipes are available now. I went to the grocery store, they're there. You can pick these up. So I would be wiping down the inside of my car and got my hand sanitizer. I'm keeping that with me, and I'm hand sanitizing before I enter. Facilities have the hand sanitizer available as soon as you enter. Sanitize your hands as soon as you get in, and then do the same thing when you leave, okay? Keep a log of what buildings you're going to, because in the event that a facility does have a case and you are a therapist who treats at that building or treated that patient, goodness, that could certainly happen. We need to know where you're going. So before, 3 months ago, we might have an evaluation because somebody fell and we needed an eval on the fly, and you were available. We called you, we sent you, and you were able to do that eval, within the day, maybe even to a building that you don't typically treat at because you were available and you offered your support. Fantastic. And we may still call on you to do that during this time, but I need for you to keep track of where you're going and who you're seeing. It's important for us to know where we're going and who we're seeing anyway, right? Because if I'm doing evals at 3 or 4 different sites, I don't know how you keep up with all of those plans because, if I'm doing all of those evals, I'm the evaluating therapist. I'm responsible for those plans of care. Like if patients aren't progressing or their goals are not being achieved, I'm the therapist who created that plan. I'm responsible. So the therapists who float typically are very organized anyway because they have to keep track of all of the patients. I mean, it could be up to 60, 70 patients that you're responsible for. There's no way to keep track of that unless you've got a system. Now more than ever, have a system. Know where you're going and who you're treating. Keep track of it so that if a patient case is identified in a building that you've provided services at, we can track where you've been and we can double check that path doesn't have any risk, or that we check your path for any potential for risk. Okay. For my floaters, for the people, the patient, the evaluators who are coming into a building to do an eval, to do an updated plan of care, to recertify a program, those are things that are required for an in-person treatment. Go straight to their room. Okay, we're not going into the gym, especially if you are someone who goes to multiple buildings. Know where you're going and go there. Make a beeline. This is the time to be connecting with your rehab directors, getting as much information, EMR information, history, things that you can get remotely. Access them safely using best judgment. Get them remotely, so that you limit the amount of traffic limit your footprint in the building. Go straight to that room and get the job done as efficiently as possible. Point A to point B. Leave your stuff in the car. Leave your phone. Leave the personal items. Leave those in your car. Don't bring all of your stuff, because then you just got to schlep it around, and then it's probably, we haven't probably cleaned it off properly. So just leave all of it in your car and, just go in, do your assessment, get the information that you need to complete your remote note, right? I would assume that if you're in this role, that you're doing the remote documentation, right? You're going off-site, you're getting your information, you're treating your patient, you're assessing your patient, and then you're taking yourself out of the situation and completing documentation remotely to reduce that risk of spreading any type of infection. So you could complete your documentation from the car, from home, personal device, just avoiding cross-contamination from laptops. So we want to try to avoid you going to the gym where there is quite a bit of patient traffic and therapist traffic. Like, let's keep you out of there. And you just go straight to your car and do your documentation on your own. Again, this goes back to the remote note and why we have offered this option to buildings that need it. If you have a full-time PT, OT, and speech therapist, evaluating therapist, this isn't an option for you because you've got a dedicated staff who doesn't float. This is for buildings that are going to struggle to find people to continue programs. And the risk there is that your patients will have interrupted services that they need, services that will keep them from bouncing back to the hospital, right? If we don't have physical therapy, occupational therapy, speech therapy, or if we have an interruption in a plan that's progressing, when that patient goes home, it's not going to be as successful as it would have been with uninterrupted service. So you have an unsuccessful discharge, and now you have a patient that's at risk of bouncing back to the hospital, and we do not want anybody bouncing back to the hospital right now. Our hospitals if they're not strapped now, they're going to be strapped for space and beds and people to take care of them. So we play a huge role in improving the effectiveness and the safety of our outcomes and successful discharges, but that can only happen if we're integrated into the programs uninterrupted. And so for that reason, you're going to have some people float around. And here we just want to offer you some options for that to keep it as safe as possible following the CDC's guidelines. I hope that you found this helpful. Please reach out with any questions or great stories to share. I have just received so many, and we'll be sharing some of those stories tomorrow. I love sharing just a fun team story or a couple team stories that you can share with your teams as well. Some positive in the midst of crazy. But I hope everyone has a great rest of your day, and reach out to me at clee, Lee, at qrmhealth.com. Thank you so much.